5 o'clock, and it's a pleasure to introduce Kåre Håkansson, who will present his study here, which you have all read in advance, and answer the questions too. Feel free to write your questions in the chat, and we will address them afterwards. All right. Welcome, Kåre.
Thank you, and hello to everyone out there who are watching, who are watching right as I speak, but also hello to those of you who might be seeing this on video as it is recorded. Hello from sunny Copenhagen. Well, actually it's not sunny at all, it's raining, and it's been raining all day. I'm excited to see at least 5 online watchers now. I hope maybe more will log in, and that we at least will have a good discussion at the end of this presentation. Today I will present some data that were generated during my PhD study that was entitled An Investigation of Coexisting Upper and Lower Airway Disease, the United Airways Further Supported. Now, this study was conducted in collaboration with my principal supervisor, the professor in Copenhagen, Christian von Bugwell. Also, other people were involved, including Klaus Bachert, who is a professor in Belgium, but also at the Karolinska University. So some of you in Sweden might know him. Today I will be talking about inflammatory airway diseases. Diseases such as non-allergic rhinitis that in Denmark affect some 10 to 20% of the population. Allergic rhinitis, 20 to 30%. Chronic rhinosinusitis with nasal polyps, about 4%. And asthma, which affects somewhere between 3 and 10%. So looking at these numbers, you might get the impression that up to 50% of the Danish population has one of these diseases, but of course that is not the case because there is a substantial overlap. So a little bit about functions of the nose. Well, the nose is part of the conducting airway, so air comes in and air goes out. It is important for the heating and moisturizing of the inspired air, and also it filtrates larger particles. A little bit about functions of the lungs. They are also part of the conducting airway, and they also filtrate particles, at least in the bronchi. And then there are some special functions such as bronchial contraction and, of course, gas exchange. So both the upper and lower airway is lined by respiratory epithelium, and both have and in the epithelium of the upper and lower airway have similar functions, both barrier and immunological functions. So despite this overlap in function and anatomy, these two organs are divided between 2 different specialties. Now, it's been known for many years, or it's been described that often disease presents itself in both ends of the airway. So not just the lungs, then there will also be disease in the nose, and this has been given many names. One of them is the United Airways, and this has been described ever since the Middle Ages, and there was a conference held in Copenhagen back in 1990 about the same issue. So this is not new knowledge, and it's a concept that is well accepted within allergic diseases, but it is still a little less well accepted for non-allergic airway diseases. Now this is an overview of papers included in my PhD study, and what I will be discussing today is this particular paper, which was a general population study including almost 3,500 participants. Now the aim was to examine the possible association between non-allergic rhinitis, smoking, and lower airway disease in the general population in Denmark. Now, I presume that you all read the paper. So I chose this paper since I think it has some weaknesses that are probably quite general to this kind of cross-sectional studies. Now, such studies are very or fairly easy to publish, but these inherited design problems have to be kept in mind when you interpret the data. I've drawn some attention to some of these weaknesses when I chose the questions for the multiple choice questionnaire, and I will also point to these weaknesses at the end of this presentation. Now, before this paper, we knew that there isn't a strong association between smoking and COPD. And that smoking harms the lower airways. So in this study, we wanted to investigate whether there is a possible association between smoking and upper airway disease, and whether there is an association between COPD, so chronic obstructive pulmonary disease, and upper airway disease. So a little bit about the methods. Some 8,000 participants were invited, but less than half actually participated. They all completed a pre-mail questionnaire, and they then came in for clinical examination, including spirometry and measurement of 4 aero allergens. Then nasal disease was categorized according to symptoms and atopy, and pulmonary disease was categorized on the basis of doctor-diagnosed asthma or spirometry in the case of COPD. So, what did we find? When we look at smoking, we saw an increasing odds ratio for having non-allergic rhinitis with increasing smoke exposure, whereas the opposite was seen for allergic rhinitis. Both asthma and chronic bronchitis was positively associated with both non-allergic rhinitis and allergic rhinitis. Signs of poor lung function was associated with non-allergic rhinitis but not allergic rhinitis. So this is a graphical reproduction of the table that we just saw, and what we see here is that there is a trend towards higher odds ratios with increasing smoke exposure in the non-allergic patients, whereas the opposite is seen in the allergic patients. So, in conclusion, smoking was found to be associated with nasal disease, especially, non-allergic nasal disease, whereas we did not find an association between COPD and nasal disease. Oh. Alright, so as I said, I picked this study because it has some design or there are some problems that needs to be discussed in this study, and probably some of these design problems are more general to cross-sectional studies, and this is why I picked the study, to keep us all aware about these problems when we read and interpret such studies. First of all, the questionnaire was part of a larger study that focused on general health. So ENT questions were not, the ENT disease was not the main focus of the study, and therefore we had to modify the data a little bit for it to make sense for us, and also probably the data cannot be directly translated into a clinical setting. We had a low participation rate, probably not much lower than other similar studies, but we did, and there's an obvious risk of selection bias because of this. Now, lucky for me, a paper came out earlier this year about exactly this issue, about characterizing responders and non-responders in this cohort. And what we find here is that amongst the responders, there were more women, they were a little bit older, they were better educated and had higher income, they had roughly the same hospitalization rate, and they had more contacts with their general practitioners. So this tells us that they are probably more the people who actually participate are probably more resourceful, and maybe they are actually a little bit healthier than the non-responders. Then we use some unvalidated and unspecific questions, which of course is a problem if we want to compare our results to other studies. And unfortunately, there was no question about disease duration. This means that we cannot differentiate between acute and chronic disease. Then only 4 allergens were examined, so of course we might miss some atopic participants, and no endoscopy was performed, meaning that we might miss or we do not know how many patients that had nasal polyposis. Then asthma was not diagnosed according to guidelines. This is also often a problem in cross-sectional studies, as it is very difficult to follow guidelines when you examine a lot of patients. We based our diagnosis on doctor-diagnosed asthma, and this means that some of the patients with asthma in this study might not have asthma, and another problem is that as asthma is probably underestimated in the general population, we might have missed some cases of asthma. COPD, we almost followed guidelines here. COPD is characterized by symptoms just such as dyspnea, chronic cough, sputum production, and more importantly, the key feature is a reduced forced expiratory volume in the first second divided by forced vital capacity. This has to be less than 70%, and this has to be measured after bronchodilation, meaning patients have to have asthma medication before you do the measurement. And just to show you, some of the people who are involved in the GOLD guideline, which is the guideline that defines how to diagnose COPD. Now, some of these people made this study in Denmark a showing that there's a high prevalence of COPD in an older cohort in Copenhagen. But in this study, they did not use post-bronchodilator data. And this just shows how difficult it is to follow these guidelines when people who make the guidelines cannot follow them themselves. Then there's the problem with overlapping symptoms. Chronic bronchitis is characterized by productive cough, and so is asthma, and so is post-nasal drip. So how do you differentiate one from the other in a cross-sectional study? Then when you examine the association between smoking and associated disease, one also always have to take into account a healthy smoker effect. And have we proven causality? I will leave this to you to discuss afterwards. Now, a little bit about perspectives, or a little data from outside the study. This is the figure that I showed you already, where we see an increasing odds ratio with increasing smoke exposure. In 2010, in the same area of Copenhagen, this study was repeated, but with an improved design. So some of the questionnaire had been improved according to some of the problems that we pointed at, and also the more allergens were examined. And when looking at these data, and these data are unpublished so far, we found essentially the same thing: an increasing trend in the non-allergic group and a decreasing trend in the allergic group. And this is another graphical, simple graphical presentation of the same data. We see these opposite trends both in 2010 and 2006. But what is striking is that actually it seems the overall prevalence of rhinitis is somewhat stable. And one could speculate whether smoking somehow just moves patients from the allergic category to the non-allergic category. And I just want to mention that in 2010, we actually did find an association between chronic obstructive pulmonary disease and non-allergic rhinitis. So, this is actually the end of my presentation. I forgot to put in a thank you and a funny slide for questions. You have to do out. I just want to say that I understand that this is the first real NERN presentation, so I want to say cheers. And thank you for being invited. It's been a pleasure so far, and I'm looking forward to your questions.
All right, thank you very much, Kåre. We have some questions here already. First, Akademiska sjukhuset, I think they wrote this when you were presenting your other studies. Are all of these studies already done and published?
I can just talk now?
Yep.
Yeah, no, 3 of the studies are published. The 4th one, which is actually the really interesting one, has also met, because it is a little bit more, I guess, controversial, which means that it is a little bit more difficult to publish. But I have a finished manuscript and will submit for the 4th time my 4th paper soon, and I'm pretty sure that it will be published soon. This paper is a paper that is about the inflammation in the upper airway mucosa in nasal polyposis compared to the lower airway inflammation, and we have some really exciting, I think, results, but so far unpublished, unfortunately.
All right, we might hear more from you then. Then Helena Fager Olsen writes, are there any explanation to why NAR is associated with smoking?
No, and as I said, well, obviously, when we set out to do this, the hypothesis was as smoking is harmful to the lower airway mucosa, so of course it is harmful in exactly the same way in the upper airway mucosa. But then when you look at these slides that I show here at the very end, you wonder whether that is the whole story, or whether, as I said, maybe somehow allergic rhinitis is just turned into non-allergic rhinitis. When you smoke, it has been discussed that smoking seems to suppress eosinophilic inflammation, and maybe smoking somehow can modify eosinophilic inflammation and allergy, so it doesn't turn off the symptoms, but maybe it turns off the eosinophilic reaction and the allergy.
All right.
It is a matter. It can be, it's a matter of speculation.
All right. We have another question from Akademiska sjukhuset. What is a healthy smoker effect?
Well, okay. It's when people. The thing is, if you have a group of patients, for example, a group of patients having asthma, then those who are really bad and feel a lot of symptoms from their asthma, they will stop smoking. Whereas there are some of the asthmatic patients might not be so sick. They don't feel a lot of symptoms, so they continue to smoke. And when you start then doing an analysis of that, and you look at which asthmatic patients are feeling sick and which one are feeling well, then you will end up finding that smoking is associated with no symptoms or well-controlled disease. But it has nothing to do with smoking. It has to do with those not being very ill or not feeling many symptoms actually continue smoking. So this is always a problem, that smoking can end up, if you just look at the data, it might look like smoking actually is good for you.
All right. That was a good explanation. I have some questions of my own, if there's none else in the chat at the moment. If you would do, this is something that we intend on asking all of our presentations here at the Online Journal Club. If you would do a Nordic study, what would you do if you wanted to do something similar, or if you wanted to do something based on this research?
Yeah, I think that it would be, and I also pointed at this as a perspective in my PhD thesis or dissertation, that I somehow think it would be a little interesting to follow a larger group of patients undergoing smoking cessation, and then see whether maybe they switch from non-allergic to allergic. You follow that? If we suspect or hypothesize that smoking can push people from the allergic category to the non-allergic category, can stopping smoking then push them back into the allergic category?
All right, that's interesting. And also, you had a collaboration with Klaus Bucket in Stockholm.
Yes.
I know he has done some studies on nasal polyps in comparing Europe to China.
Yes.
Saying that they have more eosinophilic
That's
polyps
true.
over there. Do you think that would be interesting for the upper airways and the lower airways? Some sort of combination study.
What he has shown is that in a Chinese population, well, when you look at Caucasians, and Caucasians, just for the record, means pretty much anything else but Asians. It's Europeans, it's people from the Middle East, it's Africans. Well, at least not maybe. Yeah, I think large parts of Africa. So Caucasians I think in this respect is a very broad term, but so in non-Chinese or in Caucasians, nasal polyposis is very much an eosinophilic disease. And all patients in my cohort that I did when I did a study on nasal polyposis were Caucasians as well. Anyways, then when you look at Chinese patients, it's different. They seem to be more neutrophilic, and not only that, as I showed in my study, in a European or Caucasian context, asthma is very prevalent amongst patients who have nasal polyposis. It seems to be less prevalent among the Chinese. So not only is nasal polyposis in China less eosinophilic, it is also less associated with asthma. So it just shows that a phenotype like nasal polyposis might have different pathogenical, different, like the road to that phenotype might differ. In a Nordic context, I think that would be, since we don't have that many non-Caucasians. I don't know what the relevance for that would be, since I think that we would just repeat what has been reported many times before, that the nasal polyps that we see in Denmark, Sweden, and Norway are largely eosinophilic, all of them.
All right. There are no more questions in the chat. I have one final question for you. And does this study in any way change how we treat these patients in the clinic?
See, the thing is, I would like to say that we could tell people to stop smoking when they come to, because people who treat non-allergic rhinitis will tell you that they are pretty difficult to treat. You cannot desensitize them, and they might or might not respond to nasal steroids or whatever you can throw at them. So it would be very nice if you could tell them to just stop smoking. And I guess we have not in any way shown that that is that is true, but if you from these data conclude that smoking is associated with non-allergic disease, then you might say, well, then probably you should stop smoking. But then again, if you look at the data like I presented them at the very end, that maybe non-allergic disease is simply, or when in the terms of smoking, that smoking might just suppress an allergic disease somehow, then probably patients will just stay. I don't know, they probably won't get healthy then. I don't know. Like, but that would be maybe the only thing that you could take from this, is that maybe smoking cessation should be promoted amongst patients with non-allergic rhinitis. And if it turns out that they become allergic, then maybe you can desensitize them. I don't know.
We have a question from Dagny Hemmingsen. Do smokers with NAR respond the same way as non-smokers with NAR to medical treatment with steroids?
See, now I have to say I don't really know. I just I know from discussions with clinicians and from also the general like what I've heard at conferences, and also from what I've read, that in general clinicians find that non-allergic rhinitis are more difficult to treat, both because probably it's a heterogenic group. It's not just one disease, it's probably many different diseases, and that many of them respond worse or do not respond as well to treatment. So I don't have any study results in like I can think of to back that up, but that is my impression.
All right. Then the chat is empty at the moment. And once again, thank you very much for a great presentation. We'll bring this home to our clinics. My clinic was listening, but the rest of us also. And
Okay.
thank you everyone for participating. We will send out your statistics after the presentation.
It was a pleasure.
Thank you. Bye-bye.
Bye-bye.
Hvordan ved du, hvornår den er sluppet fra?
Kom her. Altså, det tror jeg, den er nu.